Hi there, welcome to ComplyPlus Presents, and today we're going to look at how to keep health and social care policies practical and used. Today I'm joined by Dr Richard Dune. How are we doing, Richard?
Hello everyone, doing well. Another week has gone very quickly.
Excellent. So today, we are looking at quite a crucial area. The reason being, we've got a webinar coming up in a couple of weeks that is free to attend. You should see that on our socials and our website very soon. But in build up to that, there's been a lot of questions being asked around how to use policies. I've signed up for this system, whether it be on ComplyPlus or one of our competitors' systems or any system, or whether they're sitting in cupboards or files. But how actually do we use them in practice, and how do we make the most of them? So today we want to unpack why so many policies fail to impact frontline practice, explore some key elements that make policies useful, usable, and also used. Examine some real-life CQC breaches linked to policy and procedural gaps. So obviously using real-world case studies, I think, is always a good way of relating to this theme. We're also going to offer some practical ways to embed policies into daily operations. We'll also touch on that quite heavily in the webinar in a couple of weeks' time. And finally, we'll also show you how our system can also help providers align policy with regulation and best practice. We'll just give some examples on how ComplyPlus software has helped some of our current clients, and it may be useful to some of you today. So first of all, let's start with the elephant in the room. Richard, why do so many providers have detailed policies and procedures yet still get flagged during CQC inspections?
Yeah, it's a big problem in the sector, and this has been a problem for a long time, where policies are very generic. There's a tendency that people get policies from, say, providers who are providing templates, and we do provide templates as well in training on how to customize those policies, but others are just taking the templates and then placing their logo and their company name, so they're generic, not customized, and they're also outdated. Once you have a policy or a procedure, no time is taken to review it, to check that it's working as it should. And it ends up being a tick box exercise. We've got this policy and we've ticked the box. It lives somewhere, whether in a digital folder or on a manual folder, gathering dust on a cupboard somewhere. So it does not really guide frontline action. So you find actually that you've seen that as well, even in some organizations we've worked with, where what the policy says they should be doing and what they are actually doing is quite different, right? So when you look at whether it's commissioners or Care Quality Commission regulators, when they are inspecting and assessing paperwork, they are looking at correspondence with practice. Does it actually align with what you're doing in practice? They're not just auditing whether you have paperwork or not. They're checking whether you've got it and whether it's being used in practice. It's actually informing practice. And I've seen beautifully written policies that no one uses. The manager or the owner has taken time to build these beautiful policies, and quite often they're quite decent.
Yeah.
But no one knows how to use them, and they're not being used in practice, so they're absolutely no use to anyone. So we've seen regular failures, really. And even when you look at CQC data, why companies are failing, especially small to medium size, but even some of the larger NHS trusts we've seen, where Regulation 12, so safe care and treatment, when you look at Regulation 13, safeguarding people, and also Regulation 17, good governance, that's where most organizations fail. Organizations that need to improve or are providing inadequate services, those are the key regulations that they fail on a lot. So services are non-compliant, not because they lacked policies. Quite often they do have these policies, but they're outdated, they're tick boxes, and they're generic and not customized. So these policies sometimes are not known, or sometimes they are known, but they're not followed. And also sometimes they're not embedded in the day-to-day. And lastly, somebody, I think it's a quotation that I picked up somewhere, I can't remember where exactly, but somebody said a policy is only effective when it's understood, used, and auditable in practice. Right? So you don't disconnect policies from training, from induction, from supervision, from your team meetings. You should constantly be advising everything that we're doing day to day. Yeah.
Yeah. No, I think that's a really interesting quote. And like you say, these standalone services now that we're seeing in the sector, like you say, understanding the connection between all of them and also having that guidance on how they can be used, I think is where there's a real gap at the moment, even with some of the clients that are coming to us.
Yeah.
And bridging that gap and making sure these things are almost integrated in many ways is really crucial. So it's not just about having a file of documents. It's about whether your staff can apply what's written under pressure and in context. So I think really that's a really key takeaway on like I say, why most people fail the CQC on the policy side is because it is just a case of we need policy templates, we'll get them in, or we know this person down the road running a similar service, what did they use, we'll get that in, but then what happens? The action after is also the hard bit, in fairness, but that's what's needed, especially with the way CQC are regulating now.
Yeah.
So you've used the phrase useful, usable, used. Could you break that down a little bit more in layman's terms for the audience?
Yeah. So what makes a policy or a procedure useful? Right. That's a very good question. And everyone should be asking themselves that, right? So it's got to be relevant to your service model. For example, if I'm in domiciliary care or supported living or a care home, or I'm a doctor, nurse, or physiotherapist running a clinic on the high street, how is this policy or procedure relevant to my practice? Think about the service users. What are their expectations? What are the outcomes that are expected? And does this policy get you towards achieving that outcome or those outcomes? Then legally up to date, because in pretty much everything we do in health and social care, there's some law or regulation or best practice guidance document somewhere that we refer to. We always talk about evidence-based practice. And it's really crucial that we align with the latest legislation. And when there's a change in legislation, we update that policy. Then Care Quality Commission regulations are really crucial as well, because obviously that's part of the inspectorate framework. And if you're not meeting that, then you're in trouble, right? And also there's some key legislation like the CARE Act, Mental Capacity, Health and Safety at Work Act, data protection. So all these things actually can put your organization at risk in many different ways. So you want robust policies and procedures that align with the expectations of the laws of the country and also the regulations from the regulatory bodies. And you've got to incorporate sector-specific best practice as well. For example, if you are in healthcare, I remember my days working in practice, whether as a nurse or as a researcher. In the end, we looked at NICE guidelines. And whenever there was a new guideline that would inform our treatment, right, which medicines are approved for use in those particular patients, and also how often they have to come to clinic, what bloods do you need to take, all those things are crucial. But even if you're running a small care home or a domiciliary care company, there are some similar regulations as well and guidance. For example, infection prevention and control. We saw that through COVID, where it's really crucial to standardize how we approach infection prevention and control. And any lapses can cause some serious harm to people. And so Skills for Care put a lot of guidance out there for care workers, including the training as well. And Skills for Health, we've worked with both Skills for Health and Skills for Care. We got their endorsement. I think things have changed a lot now in how they work, but that guidance is crucial. Resuscitation Council UK, National Back Exchange. So there's a lot out there that you can bring in. Even commissioners, your local commissioners, they may have specific requirements. If you're in the southwest of England, for example, the local authorities or regional authorities may have specific requirements for that particular area, and you need to follow those so that you remain compliant, because quite often these are minimum standards. And if you don't meet minimum standards, then you're failing service.
Yeah, you're going to have a
And
problem.
that's where problems start.
Yeah. So, like you're saying, we often forget that usable also means usable under pressure. A frontline worker in a safeguarding crisis can't scroll through 50 pages. They're going to need clarity in that moment.
Yeah.
And I think that's another thing to sort of remember, that yes, policy can feel very heavy and dense in terms of, we've seen the folders. If we look at the old school methods, big, ring binder folders. But understanding the key aspects and mapping that then to the training, the induction, the onboarding, the supervision, that really is where the message can then hit home, because no one's going to be expected to know 50 pages back to back.
Yeah.
And I think that's a really important point there. It isn't just about reading and comprehension. It's about, like you say, how you can apply it and how you can understand the key points. So if we look at real CQC outcomes, what are some policy gaps that cause providers to fail?
I think it's important to step back again to sort of say, look, previously we were talking about useful. We need to really sort of talk a little bit more about usability. We need to talk a little bit more about usage as well. So there are some things that can enhance or hinder the usability of policies and procedures. One thing is writing policies in plain English.
Yeah.
Right? Because no matter how good somebody is with language, some of the language is quite technical. And I've seen some policies and procedures that are needlessly technical, jargon. Perhaps if you're working in an NHS trust, people use certain clinical terminology. But actually, when you go into care settings, then that needs to change because people haven't gone to university and done 3-year, 5-year, 6-year degrees to learn how to use that terminology regularly. Clarity as far as responsibility is also important, because you have various multidisciplinary teams, and each of them needs to know where the boundaries are. And policies must specify what is expected of directors and leaders, managers, what is expected of senior staff, what is expected of every level. So if a policy affects just one group of staff, then it has to be specified as such. Then you also need things like checklists. Checklists, I think, are understated.
Yeah.
I remember Atu Gawande, his book on the checklist manifesto. It changed everything. I was working in cardiology at the time, going to the cath lab, the day unit, and the wards, the coronary care unit. And checklists were crucial. It meant that we did not miss anything. It meant that actually the patient, by the time they arrive and they're ready for their operation, everything is there, has been checked and double-checked and triple-checked at every stage. So it minimizes risk of harm when you talk about safe care and treatment, Regulation 12. That's really crucial. So checklists, I'm still a big advocate for checklists. Even where you are now using digital solutions, we need to incorporate checklists into those digital solutions as well, so that we see where we are complying and where we are not. We can also root out bad practice. Because I like them, even in our business. I like checklists. I just look at them and then I do a mini audit, and it tells me quite a lot as far as what's going on. Then workflows as well. You were talking about safeguarding under pressure, for example. One of the things that came in the NHS, I think around 2009, 10, after the Mid-Staffordshire NHS Foundation Trust scandal, was around safeguarding. So they put these posters on the wall where you saw the workflow actually to say, look, if you have a safeguarding concern, how do you deal with it? So as a nurse, you're in the treatment room, you're getting your medications ready, you look up and you see that poster on the wall. That poster about zero tolerance to violence on the walls. That poster about how to wash your hands next to the sink. So those are really important little reminders and prompts within the workplace itself. Then escalation routes as well. If you raise a concern and that concern is not taken seriously or is ignored, what do? Right? So even whistleblowing, reminding people, because like say, how many policies would you have on average? I mean, these care companies will have hundreds of policies and procedures. How do you remember all of them? How do you remember all this legislation and these regulations? You need those reminders, and posters and workflows are important. accessibility of policies can also hinder
Yeah.
their
Big problem. Yeah.
usability if they're not accessible. It can be very difficult. I remember working in A&E. The last time I worked in clinical practice was around 2017. In frontline, sort of, I was working in A&E, and you could come up with a challenge out of the blue. A patient comes in and they are presenting in a way that you need to think, hang on, what does the protocol actually say? Quite often there's somebody who knows what the protocol says, but it's important for you as well to check.
And have access to check.
So access to the computer, log in, check, and then follow the protocol. Because actually, if you ask someone under pressure, that's perfectly acceptable if somebody knows what to do under pressure. But you need to be confident yourself as well to say, look, what do we do with this? What is the pathway for this?
Yeah.
There's some pathways that are there. For example, sepsis pathways, anaphylaxis, because you're using them regularly because these are regular occurrences. But what about those things that happen once in a blue moon?
Yes.
That's when some of the challenges, challenges really present. So it's important that they're available in formats that staff can use. If it's computers, people have access and they know how to use these systems. And also, can they access while they're on shift? What about night shift? What about weekend? What about bank holiday when all the frontline managers are not there? People that, a lot of them are quite senior, they don't work weekends. They very rarely do night shifts. They very rarely work on bank holidays. So not just a shared drive. People need to know, really, can they get in? Can they access? And then when you look at how a policy used, what makes other policies and procedures more used than others? I did allude to it to say, if it's a regular occurrence, then people can get really well versed. It's part of their training, it's part of their induction, it's part of the supervision and things like that. But actually, you need to build that in. You need to build that in intentionally to say, look, all these procedures, how are you going to fit them and refer to them during statutory and mandatory training? People have this tendency of boxing in, say, training provider does this, a consultant does that, this person does that, somebody's doing a mock audit. Everybody is doing the same job. I don't agree with this sort of idea that some people are more special than others or other people know more than others. If you're building training, you need to think about legislation, about regulations. Then you need to build it into your policies and procedures, your induction training and onboarding, your audits, your daily care routines, your supervision, your team meetings. All that is really important. For example, as far as complaints are concerned, we've gone into organizations where people are not sure how complaints should be handled and think, hang on, every organization, that should be the foremost thing. Because you learn from complaints. That's basic customer care, whatever industry you're in. And most importantly, where you're providing care services. So your complaints processes, your incident investigation, your incident reporting, staff reflections, and now with these quality statements, the I statements, the we statements, we need to be able to refer to these policies and procedures and use them in practice automatically. So until your staff say, yes, I used that policy last week when this happened, and they can reference that, then you still have a long way to go.
Yeah.
Yeah.
No, I think there's some really good examples there. And like you say, some real world examples that are probably happening every day up and down the country. Linking back to CQC outcomes, what examples could you give the audience on where, like I was saying, the policy gaps cause people to fail? What are the key sort of 5 examples?
Yeah. So there are many, but it's good you can limit them because we have to go to, I think we did some work a few months ago where we were looking at organizations that were rated inadequate by the Care Quality Commission. So we're trying to see what are the trends that we can pick from that. Yep. And it became very clear. I mean, I did mention Regulation 12, Regulation 13 and 17. Those were some of the key ones where almost every organization that was inadequate had failed dismally in those areas.
Yeah.
But there are other areas. But whenever I look at any healthcare, social care company, I always think about governance, right? You and I know that unless you nail governance, you're going nowhere as a business, no matter what sector you're in.
No matter what business, yeah.
Yeah, but in health and social care, it's particularly important. I come from clinical background primarily, although I've worked in hospitals, I've worked in primary care with GPs. I've also worked with care companies. I used to do some work in care homes, so, supporting care homes a lot. Governance in NHS Trust, they have better structure because they have a full board, they have advisors, non-executive directors, they've got the resources to hire people to do these jobs. They have clinical governance as well as a framework to use. Medical director, or chief medical officer, chief nursing officer, they've got people responsible for quality, for patient safety. But when you look at small to medium-sized health and social care companies, quite often the director is also the registered manager.
Yeah.
Is also doing some of the clinical work, if not all of the clinical work. I remember some years ago, they were a client of ours, actually, briefly, but it was a big hospital, private hospital, so an independent hospital that employed more than 100 people with a single director. I think, how is that even allowed? If you're providing specialist services, you're doing operations, and one person who is also the doctor doing most of the work is the sole director of that organization. That's a failure in governance straight away.
Yeah.
But actually for small to medium-sized care companies, they're small family-owned businesses, husband and wife or family members working in the business day to day. They have very little time to work on the business. And governance work is about working on the business, right? So failure, no audit trails, no policies and procedures not reviewed, not aligned with frontline work. Even when it came to recruitment, people going to work before they are cleared properly. So all these things are really crucial. What are we doing here as a business? Why do we exist? And if we are failing the service users, what is the point of even existing? So the solution there is to have a good governance structure. You don't have to hire specialist people upfront, but you can hire non-executive directors.
Yeah.
People that are not going to cost you as much money, but they'll be committed to giving you guidance. They'll come to your board meetings, and they'll help you because they've better understanding of the industry. Quite often you have people that are retired that need to while up their time, make friends with them, bring them in as non-executive directors. They can question you, they can guide you, they can advise you. So monthly governance checks, even the monthly directors meetings, board meetings, really crucial.
Yeah.
Right. Vision control logs, systems as well. Like our system with ComplyPlus, what we've done is addressed a challenge where the question is, how can I tell that people have read and understood the policy? Put it through a system so that staff read and it's confirmed that they've read, and it's their responsibility to go out there then and do a good job.
Yeah.
Right. Then Regulation 12, safe care and treatment, it's a big problem across the board, even big NHS trusts, patient safety, safety of service users, care homes. So care plans for specialist medicines, like somebody is taking medications for epilepsy. How are they managed actually? How is it incorporated into the care plans? The medicines charts errors, are they prescribed properly? Do we know the dose? Are we sticking to the times, the quantities? All those things are audited. So personalized medication risk protocols. So understanding, the risks inherent in these processes. People are now using EMR charts. You need to have prompts within those for high-risk medications and remind people what they need to do. Safeguarding, as I mentioned earlier, Regulation 13, another big one. Sometimes safeguarding concerns are not logged at all. Commissioners don't know, CQC don't know, and that these are reportable. So failure sometimes to escalate concerns. Safeguarding is everyone's business, including the person reporting. They need to be confident that the concern has been addressed. And if it hasn't been addressed, it's their duty to follow up, even if it means that they end up whistleblowing. Then so be it. Yeah. And then Regulation 11, another big one around consent, and especially relating to Mental Capacity Act. So missing capacity assessments, no best interest decisions, sometimes actually defaulting to the family when actually the family don't have the authority to make some of those decisions. And then the solution obviously is to have MCA champions within the organization. It shouldn't just be the manager who knows what to do. There should be other people who can deal with issues as they arise as well. So embedded assessment templates, training tied to real examples. So this is what I was saying. You can do generic training, online mental capacity training, but what does the policy say? How do you apply it internally within your organization?
Within your setting, yeah.
Exactly. And even within team meetings as well, bring it in as issues arise. Then another big one, Regulation 19 around recruitment. So failure, people starting work before their DBS clearance, they've not been cleared yet. References maybe have not come through. The minimum references required. Sometimes inappropriate references, like family members doing references
for their loved ones. Yeah.
You need to think about employment law. You need to think about safety of people that are getting the services and competencies as well. You need to don't just take their word that they're competent. Assess people for competencies and validate, then sign them off. So part of that induction, that first 12 weeks particularly, is to sign people off. Even if they're already nurses, sign people off on your system. Train them how to use the system. Don't assume that since they've used an electronic system somewhere, they will understand and just figure it out. It has to be part of the induction and onboarding training. So solution is HR-linked policy workflows, pre-employment checks, tracking, induction completion, and signing people off. Because it's your duty as an employer to do that. It's your duty as a manager to do that. So those are some of the examples. There's so many, we could even spend a whole day discussing them.
Yeah.
But these are some of the key ones that we've seen regularly.
Yeah. Excellent. So, like you say, a lot of these things link to sort of culture where policy is separated from action. And I think that is the underlying theme with a lot of these things, as well as some of the other variables you could argue here, like with the governance framework, the recruitment side. Yes, there may be costs incurred, but it's about having a strict process that's followed. And also, I think from a staffing roles and responsibility perspective, spreading that risk, like you mentioned the private hospital with just a sole director. What happens to that organisation if something happens to that sole director?
No one is, there's no oversight.
Yeah.
Because if you're providing health and social care services, oversight is important.
Yes.
And part of it, actually, people sometimes, they're waiting until their cash flow is in a good place. They're waiting until they get that big contract. They're waiting until something happens. But quite often, they never get there because they don't have good governance structures in place.
And there'll always be another reason.
There's always going to be a problem.
Yeah, and I think the idea of champions and so on, there's been a couple of organisations, particularly smaller care homes, where we've gone in and they've had that sort of mindset, but maybe implementation hasn't always been quite there. But I think that's a really good theme, and I know it's something that even with some of the resources we're making available on ComplyPlus, where we're trying to give people the guidance on how they can identify the right people, train them, give them the responsibility and so on. So I think that is all hopefully very useful and food for thought for some of you. So if we look at now what goes wrong, how do we get this right, what does good look like in practice? So if we're looking at embedding policy to practice in daily care, where do we start with that? What would be the strategy to get going with that?
Yeah, so there are many different things to do. Obviously, before you start anything, have the governance structure in place. Have your policies and procedures in place. Make sure that they've been checked out. Make sure that they've been peer reviewed. Make sure that they align with practice, so that by the time you hire people, from day one, they're starting their induction.
Yeah,
that's where it starts. So every new starter should know where the key policies relating to their role are, where the procedures relating to their role are. So we talk about induction and onboarding. So there's generic induction that everyone does pertaining to the business. Then there's the specialist induction, where they are now going on to their departments where they are working, where things may be different to what other departments are doing. So it's really crucial that that is done correctly. So using case examples and scenario walkthroughs, right? So even, for example, when nurses and doctors qualify, they don't just go straight to work. They're supervised.
Yeah.
Then even as they get signed off and start working more independently, there's still that supervision structure. Their work is audited. Their work is signed off sometimes. Then supervision and appraisals. Sometimes actually organizations don't have any evidence at all that there's supervision in place. No appraisals at all. Skills for Care have done a lot of fantastic work around workforce planning, even Skills for Health, to be fair. through the NHS England programs. But this is mostly in organizations that are maybe medium to large sizes. A lot of the small organizations don't even know such help exists. And even where it's there, it's huge documents, many of them.
Yeah.
Which ones do you prioritize? How do you apply them in practice, right? So this is where even we as training providers in the consultancy service, we've helped organizations to do that. And there are those people that are the so-called specialists as far as consultancies in supporting organizations. But actually, look, organizations can do this themselves. That's where, again, non-executive members come in. Advisors, you can hire advisors who just come in once a month to just do your audits. They don't need to work in your organizations every day. So it's important to ensure that within supervision and appraisal, you're bringing policy and procedures into reflective practice. For example, how did you apply safeguarding or MCA policy this month, for example? People should be able to explain that. And also where people are facing challenges with the policies, maybe there's lack of clarity, there should be that feedback loop to management. It shouldn't just be top down. Because quite often what I find in health and social care, even when I worked in practice, I relied on the healthcare assistants. They knew everything. Yeah, they knew everything. You want this documentation, you want to find where things are. They know everything. And they know what's happening with your patients every single day because they're spending the most time with them. Yeah. They're doing the fluid balance charts. They are helping them with feeding. They're helping them with all these things. If you actually work with them and value them, a lot of work will be done seamlessly without you even worrying. But supervision, formal supervision and appraisals is really crucial. The other thing is about audits and spot checks.
Yeah.
Registered managers, compliance managers, just routine. And they get people also involved in some of those audits. Because I remember a time when audits would be announced, that the last Friday of every month, the infection prevention and control team is going to blitz through all the wards. And guess what people do? They clean up everything, go to the sluice, sort the bins, sort everything, so that by the time the audit team comes in, they get 100%.
It's immaculate, yeah.
If you come in a week later, they've gone back to their normal, barely 50%, as far as compliance is concerned. So don't just audit you don't just audit whether a policy exists. You're checking actually, is it being followed? Are people following the policy? Are they using it? Can they explain it? And even when CQC come in, that's what they're looking for. Yeah. And the forms, the logs, decisions, everything is aligned. It's really crucial. Then we talked earlier about the posters and checklists and prompts. They're really important. Visual aids. Almost every care organization or healthcare organization, we have some sort of notice board where you can put these things. There are also some of those places like the treatment rooms and other areas where even staff rooms, you can put information on the walls in the staff room. So MCA flow chart, whistleblowing contacts, instant escalation steps, safeguarding, all those things are really crucial. Team meetings are sometimes also people just do meetings when there's a problem. So people just know that, oh God, we're being asked to come in. What's happened now? They should just be routine. Team meetings are about celebrating the little wins that we have, but building that culture where people know that they're valued and their feedback is important to the organization. So you can use recent complaints, incidents, and compliments as well to debrief which policies were utilized and how, and also, yes, what happened. Let's walk through actually with our policy. Let's see what it says we should have done, and did we do that? Of course, you do that when you're doing a root cause analysis as well. But actually, when you talk about root cause analysis, people think about investigations. But it can actually be part of the, celebrating these wins that we have to sort of say, look, how did we deal with this issue? There was a big complaint, and this is what we did. And we were open and honest in accordance with the duty of candor. We used our duty of care policy. You want people to get used to talking about these things without worrying or fearing, and then there are many systems out there now that you can use. We've got our own with ComplyPlus. So there's an advantage with using digital systems, but people need to know how to use them correctly, and they need to be integrated with their workflows as well. So fully editable policies, templates, but you customize them to your organization. The template is a starting point. Then you map to the CQC statements and the regulations, and you build, there must be built-in audit tools as well. Even when audit tools are manual, as long as they're followed and the reporting is there, that's okay as well. So staff reading logs from automated systems and automatic update alerts as well. When I log in and there's an alert, then it pings right in front of me. I can't do anything else unless I've read this alert. So those are some of the things that we can do to ensure that we are embedding that strategy in place as well.
Yeah, I think there's some really interesting takeaways there. Some of which are pretty much quite easy to sort of implement and get started with. Just dedicating a bit of time or time boxing, a few days a week, you could easily get a few of those things in place. Other areas, like you say, may need a bit more thought. You may need some systems, some technology. But I think there's a clear sort of roadmap there on how you can turn things around in your business.
I like what you said about time boxing. It's a term that is used in commercial, professional services, and you read about it in the Harvard Business Review, or other places like that. But actually, for health and social care organizations, time boxing is crucial. Reserving time to do your walk around.
Yes.
As a manager.
Yeah.
Reserving time to go and check the documents and do your audits undisturbed. Time boxing is absolutely crucial. Maybe we should do a whole webinar around time boxing and actually show people that it's so easy to stay on top of your governance and compliance issues by allowing just 1 hour a week, for example, to do these things.
Yeah, I think it's important because even some of the feedback I'm getting from some of our customer-facing teams in the business about, we've been really struggling to get in touch with this person. There's no response on email. We want to discuss this thing on the account, whether it's to do with a report, whether it's to do with some more courses they may need, whether things are running out, certificates, access, whatever it could be. And you sort of think, obviously from our business side, we're trying to think, okay, how are we going to engage with these people? We can't get through to them on the phone. We can't get through to them on an email. But like you say, time boxing is really critical. And in health and social care, where it's so fast-paced, every day can be very, very different depending on, regardless of what setting you're working in. I think it's really important because these things won't do themselves.
Yeah.
So you do need to make time.
Yeah.
And I think there's a nice little roadmap strategy there for some of you to maybe take away and have a little think about. So if we had to sum it up for providers tuning in, what are your top 3 messages on this theme for people to take away and digest?
Yeah, so let's go back to the top level. What is the purpose of a policy or a procedure? Just having it there is not enough. It needs to inform behavior. It needs to influence behavior and decisions every single day. Because when you think about it, we do statutory and mandatory training. How many laws in some of the core subjects that you look at laws and regulations? You're looking at over 100.
Yeah.
How are people expected to remember all these things? They're not lawyers. But actually, if you make an effort to incorporate them into training, into induction, your statutory and mandatory training, into supervision, appraisals, into meetings, then all of a sudden it becomes the way we do things in accordance with our policies and procedures.
Yeah.
Every new employee will know, and then those that are there, you create champions out of them, right? Then the other part is the policy itself. It needs to be clear, right? It also needs to be contextual, so our local context.
Yes.
Get away from those standard templates, use them as a starting point, then you customize and remove things that don't fit your organization, then add things that fit your organization. But you need to know clearly what you want your policy to state, and also regularly revisit and include your staff members as well, include your teams. You get their feedback from meetings. What do you learn from complaints? What do you learn from accidents and incidents? Then finally, with real compliance, policies and procedures don't stand alone. They work hand in hand with training and development. They work hand in hand with induction and onboarding. They work hand in hand with supervision and appraisal. Part of leadership role is to ensure that these things are aligned. And we also have a duty to audit and provide evidence, because under the new, or it's no longer new now, under the single assessment framework, the CQC single assessment framework, that's what's expected of you. You need to be able to evidence these things.
Self-evidence.
Because if you don't, and you can't, then you find actually that it's not...
Doesn't exist,
It doesn't exist. And it's quite easy. Even if you have beautifully written policies and procedures, if no one is using them, if no one is adhering to them, they're not worth the paper that they're written on, or the digital system that you're paying thousands of pounds annually for what? If you're not using them in practice, if they're not impacting the outcomes that you set out to achieve for service users in the organization.
Excellent. Yeah, thanks a lot for that. I think some very practical examples there, and also some essential things for every provider to think about. So, excellent. So, as I said at the beginning of the episode, we do have a more detailed webinar on this on Tuesday, the 8th of July. It will be at 7 p.m. in the evening. It's free to register. There will also be some nice takeaways in terms of resources and hopefully a lot of useful insights for people to take away. So please do register for that event. You'll also get a certificate for attending as well for your CPD records. And yeah, very much looking forward to diving a bit deeper into this topic. But hopefully today we've been able to give you a pretty good overview, as well as some useful practical tips to go away and consider for your health and social care business. So yeah, I look forward to that, Richard. And like I say, thank you very much for your insight today. Hopefully everyone's found it useful, and we'll be back next week with another episode of ComplyPlus Presents.
Thank you, everyone.
Thank you very much.